If you're over 60 and you're taking any kind of heart medication, a blood thinner, a cholesterol medication, a blood pressure drug, there is one category of vegetable that your doctor may have mentioned once, in passing, and then never brought up again. And most people forget about it entirely, until something goes wrong. I want to be straightforward with you about what this video is and isn't. This is not about some exotic superfood or a fringe health scare. This is about a very real, very well-documented interaction between some of the healthiest vegetables on the planet and some of the most commonly prescribed medications in the world. An interaction that can shift your stroke risk in a matter of days, sometimes faster, without you feeling a single symptom. The vegetable category is leafy greens: spinach, kale, collard greens, Swiss chard, broccoli, Brussels sprouts, the things your doctor told you to eat more of. And for most people, eating more of them is absolutely the right advice. But if you are on a specific class of medication, and a staggering number of people over 60 are, that advice comes with a critical asterisk that almost nobody explains properly. We're going to fix that today. Let's start with the medication. The drug class at the center of this is anticoagulants, blood thinners, and the most commonly prescribed one, particularly for people over 60, is warfarin, brand name Coumadin. If you've been diagnosed with atrial fibrillation, a blood clot, a mechanical heart valve, or if you've had a stroke or are at high risk for one, there's a good chance you're on it. In the United States alone, somewhere between 2 and 3 million people take warfarin every single day. Here's how warfarin works. It thins your blood by interfering with vitamin K. Specifically, it blocks your body's ability to use vitamin K to produce clotting factors, the proteins that cause your blood to clot. Less clotting activity means your blood flows more freely, which reduces the risk of dangerous clots forming in your arteries or heart. That's the whole mechanism. That's why it works. And here's where leafy greens come in, because leafy greens are among the richest sources of vitamin K in the entire human diet. Spinach, kale, collard greens. These vegetables are absolutely loaded with it. A single cup of cooked spinach contains roughly 800 micrograms of vitamin K. The recommended daily intake for an average adult is around 90 to 120 micrograms, so 1 cup of cooked spinach has roughly 6 to 8 times the daily recommended amount. Stay with me here, because this is where it gets important. When you eat a large amount of vitamin K, you are essentially adding fuel to the very system that warfarin is trying to suppress. Your body gets more of the raw material it needs to produce clotting factors. The drug becomes less effective. Your blood becomes thicker than your doctor intended. And when your blood is thicker than your therapeutic target, that window your doctor carefully calibrated your dose to maintain, your risk of forming a dangerous clot goes up, which means your stroke risk goes up, not over months, over days. Sometimes within 48 hours of a significant change in your diet. A study published in the journal Thrombosis and Hemostasis examined dietary vitamin K intake in patients on warfarin therapy and found that inconsistent consumption of high vitamin K foods was one of the most common and clinically significant causes of unstable anticoagulation, meaning the medication swinging outside its therapeutic range. Outside that range in either direction is dangerous. Too little clotting, and you risk a bleeding event. Too much clotting, and you risk a stroke. The target window is narrow, and leafy greens, eaten inconsistently, are one of the most reliable ways to knock you out of it. This is the part that doesn't get explained. It's not that you can't eat leafy greens on warfarin. You can. The problem is the inconsistency. Eating a large kale salad 3 days in a row and then eating none for a week is exactly the kind of pattern that sends your levels swinging. And most people have no idea they're doing it. So what does this actually look like in real life? Someone gets a new diagnosis, atrial fibrillation say. Their doctor starts them on warfarin, adjusts the dose over a few weeks until their INR, that's the blood test that measures how thin their blood is, lands in the right range. Everything looks stable. They go home, they feel fine, and then a month later, they decide they want to eat healthier. Maybe they read something about the benefits of leafy greens. Maybe they start adding spinach to their morning smoothie every day, or they start making big kale salads for lunch. Good intentions, genuinely good intentions, And then they go in for their regular blood check, and their INR has dropped significantly. Their blood is too thick. Their warfarin has essentially been partially overridden by the sudden flood of vitamin K, and now their doctor has to scramble to adjust their dose. And in the window between the dietary change and the adjustment, their clot risk is elevated. I see this pattern constantly, and the frustrating part is that nobody did anything wrong. The patient was trying to be healthy. The doctor adjusted the dose at the last appointment, but nobody connected those two things in the middle. The reverse happens too, and this one is actually more dangerous in some ways. Someone on warfarin is eating leafy greens consistently, salads every day, vegetables with every meal, and then they get sick, or they go on vacation, or they have a busy week and their diet falls apart. Suddenly they're barely eating any vitamin K at all, and now their warfarin, which was calibrated to work against a consistent level of vitamin K, is working too hard. Their blood gets dangerously thin, and that's when bleeding events happen. A small cut that won't stop, a bruise that spreads. In serious cases, internal bleeding. This is why the word I keep coming back to is consistency, not restriction. Consistency. Your body and your medication can adapt to almost any stable level of vitamin K intake. What neither can adapt to quickly enough is a dramatic swing in one direction or the other. And here's something that genuinely surprises people when they hear it. Research published in the Journal of Nutrition found that patients on warfarin who were coached to maintain a consistent daily intake of vitamin K, not to reduce it, just to keep it steady, had significantly more stable INR levels than patients who were simply told to avoid leafy greens. Think about that. Eating the same amount of spinach every day produced better outcomes than avoiding spinach entirely, because consistency is what the system needs, not deprivation. The takeaway here is not to stop eating leafy greens. That would be the wrong lesson entirely. Leafy greens are genuinely good for you. The fiber, the antioxidants, the folate, the anti-inflammatory compounds, none of that stops being true because you're on warfarin. The goal is to eat them smartly, consistently, predictably. Here's the practical framework. Pick a baseline. Decide roughly how many servings of high vitamin K vegetables you're going to eat per week, and then stick to that number as consistently as you can. It doesn't have to be a precise gram count. It just has to be roughly the same week to week. 2 servings of leafy greens most days? Fine. Your doctor calibrates your dose around that. 0 servings? Also fine. Your dose gets calibrated around that too. What isn't fine is 2 servings a day for 2 weeks, then none for a week, then suddenly 5 servings a day because you're trying to eat healthier. That's the swing. That's the problem. And the vegetables that matter most here, the ones highest in vitamin K, are worth knowing by name. Kale is at the top of the list. 1 cup of cooked kale has over 1,000 micrograms of vitamin K. Spinach is close behind. Then collard greens, Swiss chard, mustard greens, turnip greens. Broccoli and Brussels sprouts are significant too, though somewhat lower. Iceberg lettuce and romaine, much lower, not really a concern. So if you're someone who eats a lot of the dark leafy greens specifically, that's where your attention needs to go. And this is important. I'm not your doctor, and everything I'm describing here is general health education, not personal medical advice. If you're on warfarin and you haven't had a specific conversation with your doctor or pharmacist about your diet, that conversation needs to happen. Bring this up at your next appointment. Ask them what your current INR target is, ask them what level of vitamin K intake your dose was calibrated around, and ask them if your diet has been consistent with that. Those 3 questions will tell you everything you need to know about where you stand. What I find is that most people on warfarin were told at the start, watch your vitamin K, and then the subject never came up again. But diets change, seasons change. Your eating habits at 65 are probably different from your habits at 70. And every time your diet shifts significantly, your medication may need to shift with it. The blood test, the INR, exists precisely to catch these changes, but it only catches them after the fact, which is why being proactive about consistency in the first place is so much better than reacting to a result that's already out of range. Research published in the American Journal of Medicine followed warfarin patients over an extended period and found that dietary inconsistency, specifically irregular vitamin K intake, was responsible for a significant proportion of out-of-range INR results, many of which occurred without any change in medication dose. The diet changed, the medication stayed the same, and the therapeutic window got missed. That's the whole story in one sentence. The diet changed, the medication didn't know. There's one more thing worth covering, because warfarin isn't the only blood thinner out there, and a lot of people have questions about the newer ones. Newer anticoagulants, drugs like rivaroxaban, apixaban, dabigatran, work through a different mechanism than warfarin. They don't depend on vitamin K the same way. So the leafy green interaction that we've been talking about is much less of a concern with those medications. That's actually one of the reasons some doctors have moved away from warfarin toward the newer drugs. Fewer dietary restrictions, less monitoring required. But, and this is worth saying clearly, that doesn't mean those medications have no food or drug interactions at all. They do. They're just different ones. If you've been switched from warfarin to one of the newer blood thinners, and your doctor told you the diet restrictions are less strict, that's generally accurate. But it doesn't mean the conversation about diet and medication is over. It just means the specific chapter about vitamin K is less relevant for you. What if you're not on a blood thinner at all? What if you're just someone over 60 who takes a cholesterol medication, or a blood pressure drug, or something else entirely? Is any of this relevant to you? Okay, let me be precise here rather than vague. For the vitamin K and warfarin interaction specifically, no, this doesn't apply to you the same way. That interaction is particular to anticoagulant therapy. For other medications, there are other food interactions worth knowing about. Grapefruit and certain statins is a well-documented one, for example. But leafy greens and stroke risk in the way we've described today is specifically a warfarin story. What does apply to everyone, though, is the broader principle. Your diet and your medications are not separate conversations. They affect each other. And the more stable and consistent your diet is, the more predictably your medications can do their job. That's true whether you're on a blood thinner or not. So here's where I want to leave you. If you or someone you love is on warfarin, have the conversation, today, if you can. Not because you need to be scared of kale, but because knowing this puts you in control. Consistent diet, regular INR checks, open communication with your doctor when your eating habits change. Those three things together are what keep the system working the way it's supposed to. And if this is the first time you're hearing this, that's not your fault. This is one of those things that falls through the cracks of a 15-minute doctor's appointment more often than it should. That's why videos like this exist. Subscribe if you found this useful, and share it with someone you think needs to hear it. Take